Everything you think you know about what women want in the bedroom after 50 has been shaped by the wrong sources, and it is quietly costing couples the connection they deserve. There is a conversation that almost never happens between a doctor and a patient, a real one, without embarrassment, without vague language, without the assumption that after a certain age, physical intimacy is no longer worth discussing seriously. Today, that conversation happens, and I promise you, by the end of it, you will understand your body and your partner's body in a way that changes how you approach intimacy for good. Let us start with a truth that most people over 50 have never been told directly. The positions that felt natural and effortless at 30 may no longer serve you, not because something is wrong with you, but because your body has changed in ways that are completely normal, completely documented, and completely workable. Changes in joint flexibility, pelvic floor tone, spinal alignment, vaginal lubrication, and circulatory response all affect which positions allow for maximum comfort, connection, and pleasure. And when couples do not have this information, they either push through discomfort or they quietly stop trying. Both outcomes are unnecessary, both are avoidable. What science, real gynecological and urological research, shows us is that certain positions create dramatically better outcomes for women in terms of physical comfort, nerve stimulation, and emotional closeness. These are not opinions, they are biomechanics. And biomechanics, unlike mood or circumstance, you can actually optimize. I am Dr. Mariana, and this is exactly the kind of conversation I have in my clinic every week. Women and couples who come in frustrated, disconnected, sometimes ashamed, and leave with information that genuinely shifts things. My commitment to you is the same one I make to every patient. I will be honest, I will be clear, and I will respect your intelligence. If this is your first time on this channel, welcome. I talk about health, intimacy, and vitality in ways that most doctors do not take the time to explain. Subscribe so you do not miss what is coming next. And before we go further, drop a comment right now telling me what city or country you are watching from. This community is global, and I love knowing where these conversations are landing. Now let us get into the science. The first position worth understanding is what researchers in pelvic health refer to as the elevated posterior position, more commonly known as the modified missionary, where the receiving partner places a firm pillow or wedge cushion beneath the hips. Here is the biology. The angle of the pelvis determines the angle of penetration, which determines which nerve-rich areas are engaged. In standard flat missionary, the angle often bypasses the anterior vaginal wall, the area associated with what researchers call the G-spot, a concentrated cluster of nerve endings connected to the internal structure of the clitoris. When the hips are elevated by even 15 to 20 degrees, the angle of contact shifts forward, directly engaging that anterior wall. Think of it like adjusting the beam of a flashlight. The light source has not changed. The bulb has not changed. You have simply redirected the beam to illuminate exactly what you intended to reach. For women over 50, this position carries additional benefits. It reduces lower back strain for both partners. It allows the receiving partner to relax the pelvic floor, rather than contracting it to compensate for an awkward angle. And a relaxed pelvic floor is significantly more responsive. Many women in perimenopause and beyond experience hypertonicity, meaning chronic tightness in the pelvic floor that actually reduces sensation. Any position that allows relaxation is a position that increases pleasure. The dignity of knowing this, of understanding your own anatomy clearly enough to make one small adjustment with a pillow, is something I wish every woman had access to far sooner. The second position science strongly supports for women's satisfaction is side-lying, face-to-face, sometimes called the intimate spoon or the facing lateral position. This one is backed by multiple studies on women with conditions including dyspareunia, which simply means painful intercourse, and pelvic inflammatory history, both of which become more common after 50. In side-lying face-to-face positioning, penetration depth is naturally limited by the geometry of the position itself. This is critically important because for many women, especially post-menopause, deep penetration causes discomfort due to cervical sensitivity and reduced vaginal elasticity from declining estrogen levels. The limiting of depth here is not a compromise, it is a feature. The outer third of the vagina contains the highest concentration of nerve endings. Research consistently shows that stimulation of this zone is more reliably tied to pleasure and climax than deep penetration, which primarily stimulates the cervix, a less sensory-rich structure for most women. Beyond the physical, this position allows for sustained eye contact, chest-to-chest closeness, and natural synchrony of breath, all of which have been shown in relationship research to activate oxytocin release, the bonding hormone. For couples who feel emotionally distant or whose intimacy has become mechanical or performance-focused, this position is physiologically designed to restore connection. I want to stop here for a moment and ask you something directly. Of the positions we have discussed so far, which one feels most relevant to where you and your partner are right now? You do not have to go into detail, just drop a number in the comments, 1 or 2. I ask because your answers shape what I prioritize in future videos, and because knowing you are actively engaging with this material matters. The third position is one that women in clinical surveys consistently rate highly for their own satisfaction, but that couples often underutilize: the receiving partner on top, in a slightly forward-leaning orientation, what is sometimes called the cowgirl forward lean. Here is why the science supports this so strongly. In this position, the receiving partner has full control over angle, depth, rhythm, and pressure. This autonomy is not merely psychological, it is neurological. Research in sexual response shows that when a person feels in control of the stimulation they are receiving, the parasympathetic nervous system stays dominant. When the parasympathetic nervous system is active, the body remains in its arousal state, blood flow is sustained, lubrication is maintained, and the muscular relaxation required for pleasurable sensation is preserved. When control is external, when the receiving partner is responding to someone else's rhythm rather than their own, the sympathetic nervous system can begin to activate, which is the stress response pathway. Even mild anxiety or the effort of communication can trigger this, and the body begins pulling back from full arousal. The forward-leaning variation specifically aligns the front wall of the vagina with the point of contact and allows the clitoris to receive indirect pressure through movement, a mechanism that studies show is present in the majority of women who experience climax during intercourse. For women in the 50-plus age group who experience longer arousal timelines due to hormonal changes, having this level of control over pace and pressure is not just preferable, it is often clinically necessary for a fully satisfying experience. This is information that should be in every postmenopausal health conversation. It rarely is. The fourth position is one that many couples have abandoned because of back or hip pain, not realizing that a small modification transforms it entirely. The standing rear-facing position, adapted for comfort using a supportive surface, a bed edge, a countertop, whatever is the right height. The urology and gynecology research on this position focuses on two things: pelvic tilt and spinal neutrality. In standard rear-facing positioning on a flat surface, both partners often arch their lower backs in ways that compress lumbar vertebrae and create tension in the hip flexors. This is especially problematic for men over 55 with any degree of lumbar disc issue and for women with anterior pelvic tilt, both of which are extremely common. The standing variation, where the receiving partner leans forward at the hips while supported, achieves a natural posterior pelvic tilt. This opens the pelvic outlet, reduces lumbar compression, and, critically, angles the vaginal canal in a way that creates direct, sustained contact with the anterior wall without either partner having to work against gravity or maintain an uncomfortable static posture. The practical action here is straightforward. Identify the surface in your home that puts the receiving partner's hips at or just above the height of the other partner's hips when standing. That height is the optimization. Everything else follows naturally from that geometry. The fifth position, and perhaps the most undervalued by couples who have not thought about it this way, is what I call the supported recline. The receiving partner leaning back against a firm incline, such as a wedge pillow, a sofa back, or a stack of firm cushions, with the giving partner either kneeling or seated facing them. What makes this position clinically remarkable is what it does to the pelvic floor and the deep vaginal tissues simultaneously. When the torso is inclined at roughly 45 degrees, not flat, not fully upright, the natural anatomical angle of the vaginal canal aligns almost perfectly with a forward-facing approach. This means contact with the anterior wall is effortless. The pelvic floor, rather than working to compensate for gravity or maintain position, rests in its most natural supported state. For postmenopausal women experiencing thinning of vaginal tissues, a condition called genitourinary syndrome of menopause, which affects more than half of women after menopause and is chronically underdiagnosed, this position minimizes friction against the more sensitive posterior wall while maximizing engagement with the nerve-dense anterior structures. It is, from a purely anatomical standpoint, one of the most friction-efficient and sensation-rich configurations available to couples in this age group. The supported incline also benefits couples navigating differences in joint mobility. Neither partner is required to bear their own weight in a static position. Neither partner needs full hip flexor range of motion. It is, in the truest sense of the word, an adaptive position. And adaptive does not mean lesser. It means intelligent. Let me tell you about a patient I will call Helena. She was 63. In a long marriage she described as loving and stable, but she came to me with quiet grief. She said that intimacy had become something she endured rather than enjoyed, not because of anything her husband did wrong, but because nothing quite worked the way it used to, and neither of them knew how to talk about it. She felt she was letting him down. He felt he was hurting her. They had both quietly started avoiding the conversation altogether. We spent one appointment talking through anatomy, positioning, and what her body specifically needed at this stage. No prescriptions, no procedures, information, and a referral to a pelvic floor physiotherapist. She came back 3 months later and told me that things had changed more than she could have imagined. Her words, "We feel like we found each other again." That is what access to correct information does. It is not a small thing. It is one of the most profound forms of care a couple can give themselves. I want to speak to anyone listening who has been thinking, somewhere in the back of their mind, that this stage of life simply does not include this kind of pleasure anymore. I want to address that thought directly, by name. You are wrong, not in a dismissive way, in a biological way. The research is unambiguous. Women remain sexually responsive and capable of full, satisfying, intimate experiences into their 70s, 80s, and beyond. What changes is not the capacity, it is the conditions, and conditions, unlike age, are adjustable. What many women experience after 50 is not a loss of desire, it is a loss of comfort, a loss of context, a loss of the right information arriving at the right time. That is a system failure, not a personal one, and information is the correction. The word that comes to my mind when I think about what every woman deserves in this area is dignity, the dignity of understanding her own body. The dignity of not having to accept pain or disconnection as the price of growing older. The dignity of a conversation like this one, honest, respectful, and grounded in science. Let me bring everything together into actions you can take this week. 1. Try the elevated hip position using a firm pillow or wedge beneath the receiving partner's hips. Notice whether comfort and sensation improve. 2. Explore side-lying face-to-face positioning, particularly if deep penetration causes discomfort. This position naturally limits depth while maximizing emotional closeness. 3. Prioritize the forward lean receiving partner on top position as a regular part of intimacy, not as a variation, but as a primary approach, especially for longer, more relaxed encounters. 4. Identify a surface in your home that allows the standing rear-facing adapted position at the correct hip height. Comfort and spinal alignment change this position completely. 5. Experiment with the supported recline using a wedge or firm cushions at roughly a 45-degree incline. This is particularly valuable for women navigating postmenopausal tissue sensitivity. Your 30-day invitation is this. Try one new position per week for the next 4 weeks. Approach it as curiosity, not performance. Talk about what you notice. That conversation alone, open, non-judgmental, genuinely curious, is one of the most intimacy-building things a couple can do. If this video has been useful to you or to someone you know, please share it. Hit subscribe so you continue to receive this kind of practical, honest health content. And leave a comment below answering this. Which of these 5 positions are you most curious to try first? 1 through 5. That is all. I read everyone. Aging is not the end of vitality. It is an invitation to live smarter.